For chapter 17, this is a pretty lengthy chapter. It talks about the different mood disorders. The main ones that we're going to talk about are depression and bipolar, and then it also talks about suicide. So I'm going to be making 3 videos for you to study. So if there's one particular area that you're struggling in, it'll be easier for you to study that way. So this first one is going to cover just an overview of mood disorders and then depression. So mood disorders, they are characterized by a significant disturbance in one's persistent emotional state, which basically means that they affect a person's everyday, just their everyday emotional state. They are manifested by depression, mania, or both, and there are varying degrees with all of those as well. It's important to remember that mood disorders are the most common psychiatric diagnosis that is associated with suicide attempts as well. So there are 2 primary categories of mood disorders, and they are depression and bipolar. These related disorders classified with similarities to mood disorders of depression or bipolar. So we will talk about persistent depression or depressive disorder in just a few slides. Seasonal affective disorder, or SAD. This is a type of depression that's related to changes in season. SAD begins at and ends about the same time every year for that person. The most common is called winter depression. So late fall through winter, early spring, they'll have a cycle of depression and they'll see that every year. But it could also be spring, summer, and then taper off in fall as well. So it just kind of depends on the person, but the most common is going to be your winter depression. SAD is usually treated, especially with the winter depression, with light therapy, and then also your antidepressants. Now, the antidepressants, they're just going to be given during that season, so they're not going to be taking it year-round. They're just going to be taking it during that season whenever they need it. A person can have postpartum depression, which I'm sure that you guys have heard about, but there's also postpartum psychosis. And this is a true medical emergency because it puts the newborn at a very high risk of being harmed by the mother. So let's talk about depression first. And the first one is going to be major depressive disorder. Most people feel sad or low at some point in their lives, but major depressive disorders, sometimes known as just the common language as clinical depression, is marketed by a depressed mood for most of the day for at least 2 weeks, 2 consecutive weeks. With major depressive disorder, it may be difficult to work, study, sleep, eat, be with friends, and just enjoy your activities that you like to do. Some people have major depressive disorder only once in their life, while others are going to have it several in their lifetime. So each time they have an event of depression, it's going to increase their likelihood of having another event of major depression. Patients, they must have at least 5 of these symptoms that occur nearly every day for most of the waking hours during the same 2-week period. So depressed mood, anhedonia, they're going to have loss of energy. They can either have significant weight gain or weight loss, either way. It has to be more than 1% total weight, body weight over a month, so either increased or decreased. They can either not sleep or they sleep all the time. They're going to have either decreased or increased motor activity, poor concentration, can have suicidal thoughts, and feelings of worthlessness or inappropriate guilt. Persistent depressive disorder is a less severe form, but more chronic. While it's usually not disabling, persistent depressive disorder can prevent a person from functioning normally in daily routine and from living life to its fullest. The signs and symptoms are the same as major depressive disorder, but they only need to show at least 3 of them. So with major depressive disorder, they had to show 5 or more, and with persistent depressive disorder, they only need to show 3 or more of them. Now, patients with the persistent depressive disorder, they are at a risk for developing the major depressive disorder. Just review this slide to help you distinguish between the two. Depression is thought to be genetic, and make sure that you know that it can be as a result of low serotonin and also low norepinephrine as well. So assessing a patient with depression, you'll be able to tell a lot just by the way they look physically, by their physical appearance. Oftentimes they'll seem unkept, and they may have a poor posture, sad facial expressions. The way that they think of themselves is they'll think they're worthless, that they can't do anything, and they'll have poor judgment and then remember the suicidal thoughts as well. So when a patient is in a current depressive state, they won't want to answer your questions with much effort. It's going to be yes or no questions, or it's going to be I don't know most of the time. Even if they do know, they just don't want to answer your questions because they don't want to put out the energy to do that. So they can show us signs of anxiety, hopelessness, helplessness, anguria, anhedonia. Remember, anguria is lack of energy, anhedonia is a lack of pleasure or enjoyment. So during a depressive state, they will more than likely be unable to fill their roles, whatever their role is. Is it a spouse, parent, employee, etc. Remember, depression is not a normal part of aging. Just like when we talk about pain, pain should not be considered normal whenever we get older. There's a reason for the pain, and the pain should be treated. Depression is the same. It's not okay for us to think, well, they're older. Depression is just expected for that cycle of life that they're currently in. So just remember that in practice. It's not a normal part of aging. So some interventions. Some nursing interventions for depression would be, first, to make sure that they are safe, as depressed people are at an increased risk for suicide. Also know that you need to assess for suicide risk even when they are taking antidepressants, especially when they are first started on an antidepressant, because that's going to give the patient an increased activity, and it's going to increase their mood, and so that's going to provide them the energy for their suicidal patients to actually carry out the act. Have a therapeutic relationship and use therapeutic communication. Encourage patient to perform their ADLs, and you may have to tell them, give them one step at a time to complete it. If you say, okay, go get ready for the day, well, they're not going to do that. You're going to have to say, okay, go brush your teeth. When they get done with that, you may have to tell them, go ahead and brush their hair. Just give them one step at a time. We also need to provide medications and teach the family and the patient the importance of compliance with their treatment plan. Make sure you read over these. That's a good slide. For your antidepressants, remember, teach the patients it will take a few weeks for the effects to take place. And do not abruptly stop taking the medication. It needs to be tapered off. And also the possible suicidal potential when starting antidepressants. SSRIs. Remember, serotonin is low for a patient with depression, so the SSRIs help by blocking the reuptake of the neurotransmitter serotonin in the brain. SSRIs are the first line of treatment for depression, and they include those medications such as Prozac, Celexa, Lexapro, Paxil, Zoloft. For this slide, make sure that you understand if a patient complains of dry mouth, which is a common side effect, that we're going to encourage them to use the sugar-free beverages or hard candy to treat that. Look at the Prozac. If they complain of nervousness, administer in the AM. If they complain of drowsiness with this medication, have them take it in the PM. That's the same throughout. If they complain of being drowsy, then they need to take the medication at night instead of in the morning. So one caution you need to remember for a patient taking SSRIs is the serotonin syndrome. Serotonin syndrome occurs when there is too much serotonin in the system. So symptoms will usually begin 2 to 72 hours after starting the medication. And these symptoms, they can range. They can be mild from just shivering and diarrhea, or they can be a severe form such as your muscle rigidity, fever, seizures. If your patient is suspected of having this, you're going to first, automatically stop the medication and treat the symptoms that they are displaying with this. St. John's wort, sometimes this is over-the-counter medication that patients take to help treat their depression, and it's important for us to always assess the over-the-counter medicine, not just their prescription medications, because St. John's wort, it helps to increase the serotonin in the brain as well. So if you're combining an SSRI with St. John worts, then you're going to put them at an even increased risk for developing serotonin syndrome. Tricyclic antidepressants. This is the oldest class of antidepressants, and they're not used as often because there's many contraindications with this class. Some of these contraindications are if you have impaired liver function, cardiovascular disease, glaucoma, renal impairment, diabetes, hyperthyroidism, respiratory disorders. So as you can see, that took a lot of the disorders throughout the body. So this is often not used, but still prescribed. The most common is going to be your amitriptyline or your Elavil. The side effects of this class are going to be your orthostatic hypotension, anticholinergic effects, and can also increase risk for seizures for someone who is prone to them. So make sure to know that if a patient has a history of seizures, they are not allowed to take this classification of medication. Also, this class should probably be taken at night due to the sedation effect that it produces. MAOIs, they are also infrequently used due to the many adverse effects and also the food-medication interactions. Nardil is the most common MAOI here. So the main thing to remember is for a patient that's taken an MAOI is the risk for hypertensive crisis when they ingest the thoramine found in the bear, wine, aged cheese, organ meats, avocados, and other foods. So even whenever they stop taking the MAOI, they need to refrain from these foods for at least 2 weeks afterwards as well. MAOIs, they should not be taken with other antidepressants, and they should be stopped for weeks before trying just a different classification of antidepressants. So if they're taking MAOI and they need to get them off that and they're going to try SSRI, they're going to have to wait a few weeks and be off of it completely before they start the SSRI. Read through this slide as well. And these are, whenever a patient does not respond to medications, these are the procedures that could be done to treat when they don't respond to medication. So make sure you read over these. There's a little video there so that you can watch an ECT occur. And just know that a patient ECT is done for a depressive patient. There is a possibility that the ECT can actually cause mania in a person. And so when that occurs, their depression diagnosis will be changed to a bipolar diagnosis. And that's new for the DMS or DMS-5 category. So that's new on that. Just read over those. You remember you have a sheet to fill out on the ECT. And the next video will be about the bipolar.